konuşmasından ötürü çok teşekkür ediyoruz. İnşallah bundan sonraki dönemlerde de beraber olacağız. Şimdi yurt dışından bir misafirimiz var. Kendisi kolorektal cerrahide, özellikle fistülalarda, kök hücre ve rejeneratif uygulamalarda ki tecrübelerini anlatacak. Bu konuda da Türkiye'de hani yavaş yavaş duyulmasını ve bizlere örnek olmasını istediğimiz bir konu. We would appreciate he came from very unlucky flights, but finally he made it, and sure we want to hear what he had done, and after 3-year experience we would like to see his patients and the results. Please, we would welcome Professor Dr. David Borowski.
Ladies and gentlemen, thank you very much for the invitation, Nathan, to speak here to you about the use of stem and regenerative cells in colorectal surgery. I will just plan the discourse here. Start to give you a little bit of background on the treatment of fistula in anal, which is the focus of our study, which may not be too familiar to all of you. I will then also talk a little bit about the background to fat grafting, basically, and then come to the results of our study. Now, fistula in anal is a relatively common problem. It affects more males than females, and it's most commonly based on cryptoglandular infection, so infection in the area of the anus. There are two main types. It usually just presents as an abscess. Here an ischiorectal abscess, which then develops fistula. Here are loads of fistula in a patient with Crohn's disease. Crohn's disease is probably the second most common, followed by some other less common causes. Patients usually present with an abscess or some kind of infection. Now, first of all, it's important to control the sepsis or this abscess. Usually it's done by drainage. We've got a perianal abscess, and it's an ischiorectal abscess. A perianal abscess here tracks down in the intersphincteric groove. There's the internal anal sphincter, the external anal sphincter, and the perianal abscess tracks down this way, or it can go through the sphincter and create an ischiorectal abscess. In some cases, it can also go up or come from the rectum and cause a suprasphincteric abscess. After the drainage, we need to identify where the tract or tracts are, and frequently we employ the technique of a seton, which is a rubber suture basically through the tract to allow the relief of the infection and the drainage of the abscess for a period of time. It is then important to identify the anatomy of the fistula. Where is the internal opening, where is the external opening or openings, and where do the tracts go, and where are any collections which are close to it. We have got a few rules to show us how to deal with this. One is we've got parts classification to see where the tracts may go, and it is important to exactly identify where these tracts are. We've got the intersphincteric fistula, which is only coming down in the intersphincteric space, and the internal sphincter is involved. If it's not much involved, this can be treated fairly simply and straightforwardly. We've got the transsphincteric fistula, and it's important here to identify whether the tract is low, so does not involve a large amount of sphincter in proportion, or whether it is higher up and involves a large amount of sphincter. We've then got the more complex, the suprasphincteric fistulae and the extrasphincteric fistulae, which are rather complicated. That's the classification which we need to identify. We also need to identify where are the external openings and where are the internal openings. Now we've got, yeah, we've got the Goodall's rule. Well, I mean, it's not a rule, but it's a very common finding. Is if the fistula is anteriorly, then the external opening should correspond to the internal opening. So it's more likely to be a straight tract. While if it is posterior, then there's two things can happen. It's a posterior horseshoe extension of the fistula, and the external opening frequently does somehow converge to the internal opening in the posterior midline. In addition to our clinical evaluation, we have got the MRI evaluation of collections, which are usually showing up bright yellow on the T2 sequences, and the endo-anal ultrasound scan to detect the track directions. So these are all helpful methods to treat, to identify the anatomy. Once the sepsis is eradicated and we've identified the anatomy, then we are talking about the definitive treatment. I mentioned laying open is the best possible outcome with about 95% reported healing rates, but can only be employed really to fistulae which are low or sufficiently low that we don't cause incontinence, because as sphincterotomy in effect can cause incontinence, and the more sphincter we sacrifice, the more likelihood that there will be a risk of incontinence. A slower form of cutting is a tight seton, where we put a tight rubber band around the sphincter and it cuts through with time. We give it a few weeks or months and it slowly cuts through, replaced by fibrosis at the back of this. The more complex procedures are those of the advancement club, which is probably so far the gold standard, although the healing rates are not particularly good. They range from 20%, well, in the literature, to up to 80% in good specialist centers, and most surgeons in the UK would probably quote about 50% healing rate. So it's not the gold standard with the with the good outcome in many cases. So it's an advancement club closing the internal opening, and then let the external part of the tract is debrided, and it fibroses out to the outside. Recently, a procedure, a so-called lift procedure, has come in. Is a cut into the intersphincteric grooves. The fistula tract is identified and then divided. That has got fairly good results, but again, we're dealing with a sphincter, and there might be a risk of incontinence, which has to be observed. The second group of procedures, which has come in over the last 10 years or so, are those with biological materials, in particular fibrin glue, which is basically the injection of fibrin glue into the tract to try to obliterate the tract after the eradication of sepsis. Variable results. Some studies have found that there was a 0% rate of healing. It's probably somewhere about 1/3 of patients who might heal. So it's not the answer to the treatment. Currently, there's a lot of interest in the collagen plug, where, like a wine cork, a plug is pulled into the tract in the order to start a fibrosis and closure of the fistula. That is currently under investigation in various trials. In the UK, we've currently got the Fiat trial going, fistula in anal trial, which is still recruiting patients. There were some other studies around the world which have found that it was, again, not particularly the answer to this difficult problem. And it was not superior to the comparator group. So overall, in a Cochrane review a couple of years ago, it found that there were very few randomized trials. There was no particular major difference between the different treatment options, and the comparisons were not really made. So we don't really know how to best treat these fistulae. In 2003, the regenerative medicine has come to the fistula, and García Olmo in Spain did treat the first patient for a rectovaginal fistula in Crohn's disease. He did use the lipoaspiration procedure similar to what you've seen earlier on in a very good detail. and then did a manual wash and digestion process, and in vitro cultured the stem cell, expanded the stem cells for about 4 days, and then achieved, together with fibrin glue, achieved the closure of the rectovaginal fistula at 3 months. No long-term follow-up was published on this. Garcia Olmo did follow this up in 2005 with a phase 1 trial on 5 patients, 10 fistulae, with Crohn's disease. He used in vitro cultured stem cells in fibrin glue, and this highlights, in a way, some of the problems with the in vitro expansion. 2 patients did have couldn't undergo the second procedure, the injection procedure, due to in vitro infection. In the 8 fistula which were ultimately treated, 6 healed, so giving an initial healing rate of 75%. Garcia Olmo then went on and published in 2009 a phase 2 trial on almost 50 patients, both with cryptoglandular and Crohn's fistula. Same technique, in vitro expanded adipose-derived stem cells in fibrin glue versus a control group of fibrin glue. The fibrin glue control group does illustrate, to some degree, the poor rates of fibrin glue reported in some of these studies. They found a significant difference in the healing rate with the addition of the adipose-derived stem cells. There was no difference between Crohn's and non-Crohn's patients. However, in the initial paper did report an almost 20% recurrence rate in the stem cell group. Again, and in 2012, so this year, there was a follow-up on the long-term patient. It was 12 patients which were followed up. The 12 patients which healed initially in this group, and that then found that only 58% of the initial responders showed actually long-term healing. So there was a 42% further rate of recurrence, which in just this month there was a good review from one of my colleagues from the UK, Peter Loomis, in colorectal disease, which had just come out this December, and he basically calculated that 33% only did heal in this group. Bone marrow stem cells have been tried in Italy by Chico Ciocchio, who published last year in Gut. He treated 12 patients, most of them had fistula in energy to Crohn's disease. 2 patients were not treated, and they had repeated injection of bone marrow stem cells, pure, and that showed a complete fistula closure in 70%. All patients showed, in addition to that, to the clinical healing rate, it showed that there was a reduction in the Crohn's disease and the perennial disease activity index, and also quality of life was improved. The MRI assessment in the study also showed indication of tissue regeneration. We've heard about the bone marrow and the adipose tissue. The adipose tissue does change considerably in the adult population, depending on the circumstances of nutrition, physical activity, and so on. The volume change is mediated by changes in the size of the adipocytes, and that needs to be facilitated through blood vessels, which are being, or need to be increased or decreased depending on the status of the patient. And therefore the vascular cells, particularly in the adipose tissue, are in a state of a constant plasticity to those in other tissues, more than in other tissues. In addition, we know that there are, one of the reasons behind that is actually that it is a rich source in stem cells, and we find that about 1% of the nucleated non-fat cells, in fact, are actually stem cells, or 1.5% were in that range. And that makes it actually the richest source of stem cells compared to bone marrow, where there's an age-related decline of the stem cells, and you find that it's around about 1,000, as you said earlier on, 1,000 times greater than the bone marrow stem cells found in fat. These stem cells are known to have the potential to differentiate into nerve tissue, muscle tissue, cardiac muscle tissue, into blood vessels, prune the capillaries, draw the the capillaries and also into mesodermal tissue. When we want to get to the stem cell fraction, we need to follow the process of lipoaspiration, then the digestion, enzymatic digestion of the stromal vascular fraction, which are all the nucleated non-fat cells, and then it needs to be cultured and expanded. Over the last 10 years, there has been a lot of interest in the stromal vascular fraction itself. The stromal vascular fraction, you just heard in the previous talk, is rich in a number of cells and also can be harvested or processed in an automated way, which then eliminates the problem of having a lab and having all the legal issues about cell manipulation, which is there with overnight storage and things like that. The cells in the stromal vascular fraction are nowadays called the adipose-derived regenerative cells, and as you can see, there's 1 to 5% stem cells in that, and this output is actually fairly constant. There have been studies done that they are very constant in the proportion in the patient. It might go down a little bit if you've got a very fat patient or a patient who's older, but the proportion of cells is fairly constant in the output. So we've got endothelial cells and progenitor cells, with smooth muscle progenitor cells, we've got blood cells, tissue macrophages, precursors of fat cells, and stem cells. And this cocktail of cells does exhibit a number of effects, which is mediated by growth factors and cytokines, and many of them have been found. And that makes it important in a number of aspects of wound healing, increasing of the blood supply, as we said, the new capillaries, or the ingrowth of capillaries, particularly in hostile environment where there is ischemia and hypoxia present. It is also immune modulating. It is actually honing in, and it hones other cells to the site of injury, and they work best in a freshly induced injury situation. I'm not going to go too much into lipomodeling because that was actually very well covered just now. We know that lipomodeling with enhanced ADRC enhanced grafts do improve the long-term retention of the fat grafts. In the UK, if I can just give you a little bit of background, the issue about using it in aesthetic surgery has been a very contentious one, and there was a lot of debate in the UK, and it's still not quite as accepted probably as here. In our institution, and together with few centres in the UK, we have been focusing on my breast and oncoplastic colleagues have been focusing on the reconstruction of breast after breast conserving treatment with some defects or radiotherapy, and had quite remarkable results. The trial, which has been published just this year by Dr. Iva Waller-Mithoff from Glasgow University, who's working together with our breast and reconstructive surgeons, it was a RESTORE 2 trial. It was a prospective single-arm multi-center trial on 71 women who were enrolled with previous breast-conserving cancer treatment with and without radiotherapy. 67 of these did complete the follow-up. They all underwent a lipoaspiration procedure, the processing of the ADRCs through the solution systems, so the automated system in the operating room, and then the re-injection of an ADRC-enhanced fat graft. 24 patients did require repeat treatments, and the satisfaction score was good. The 6-point Likert scale, satisfied, very satisfied, extremely satisfied in the majority of investigators and patients. The quality of life scores was stable, and there was no procedural or in particularly of concern, and no oncological adverse events in the 12-month follow-up period. On the MRI follow-up, it was also found that progressively, even over the follow-up period, not only was the tissue defect regenerated, but there was actually regenerative action continuing after the initial treatment. A brief briefly on chronic wounds. In chronic wounds, the healing process is thought to be arrested with a chronic inflammation in a status of local hypoxia, which is particularly facilitated by radiotherapy. There is always usually some bacterial colonization, continuing injury, and local solid infection. And the local healing mechanism of the body are aged, basically. They don't work as well anymore. And the theory is that the addition of the stem cells and the regenerative cells both can express growth factors and modulate that environment to improve the microenvironment with circulation, where new cells which are honing in and taking other cells in to improve the microenvironment for healing. There's a lot of work now starting in chronic wounds, and this is a case which has been reported from Japan. An old lady who had a radiation-induced bone injury over the sacrum, and that was exposed for more than 4 years, and it was resistant to conventional treatment. The treatment was debrided. The ADRCs were injected irregularly on the wound, and on the collagen sponge, 10% were placed into the wound. And following 4 years of non-healing, after roughly 6 months, the wound was closed. And it's a 90-year-old lady. There's a series of 20 patients from Italy after radiotherapy damage, and they were treated also with lipoaspirate transplant with a similar technique to the solution one, and that showed also progressive regeneration, formation of new vessels, and the tissue water content was also improved. Now, this is all background to how we came to think about the fistula. So we have got stem cell work from Spain in our breast, non-plastic surgeons have been using it for breast augmentation after cancer treatment. So we came up in 2009 with a phase 1 feasibility study for patients with complex perianal fistula. Complex being defined as patients which cannot be laid open, surgically laid open. With full ethical and institutional approval, and the funding was obtained through our local R&D department. All patients obviously underwent informed consent for the operation and for participation in the study. We had quite stringent exclusion criteria because of the underlying fear or the unknown issues about the cancer risks. We excluded everybody who had a fistula due to cancer, clearly, and those who had a fistula or any form of active malignancy within 5 years. Patients which were unsuitable for liposuction also were excluded. Pregnancy, breastfeeding, I'm sure you've got similar exclusion criteria for the liposuction here. Patients were admitted on the day of surgery. The kit which we use is very similar to what we've seen there. It's a manual lipoaspiration, so it's a low vacuum suction. Initially it was done by our plastic surgeon, but I've actually, in the latter part of the study, I've actually done also some with supervision of the plastic surgeon that we don't leave defects. I think that is a risk there potentially to create asymmetry where there wasn't, and patient might be unhappy about that. So it's quite important to do that correctly. We use a tumescent technique, and we usually maintain about 300 to 400 mils of fresh fat. Usually in most patients the anterolateral abdominal wall or from the thigh in females in particular, and then we follow that up with a pressure dressing. There's a procedure as we've seen before. We then processed the graft in the solution, which the solution machine has got a disposable kit, which includes all the disposable elements of the washing machine, and also a proprietary enzyme, SLAs, which is doing all the enzymatic digestion automatically. The beauty, as I said earlier, is that the solution machine works in real time. It takes about 90-minute turnover time to get the ADRC stromal vascular fraction. we always had one syringe back of good-looking fat, and took the fresh fat as a carrier for the cells. The solution output is constant at 5 milliliters of the cells, and we suspended them usually in about 20 to 50 mils of fat, depending on the length and the width of the fistula. We place the patient in a legs-up position, in a lithotomy position, identified the fistular tract. Most patients had a aceton, a rubber tube in there for drainage of the area. We then closed the internal orifice with an advancing flap and debrided the extrasphincteric tract, and then following that, we injected into and around the tract to literally obliterate the entire tract and the entire salivary dead space in the fistula, so completely compress the whole fistula. We've seen a very good picture of this layer technique of the technique they believe like a toothpaste, a long strip of toothpaste tissue there to increase the tissue density and compress the tissue around the fistula to completely close it. A helpful device we find is the cell brush, which is a very good device to deliver a very controlled pressure and to allow this long strips of fat being placed on withdrawal of the needle. I've got a couple of patients here, patient pictures. This was a 38-year-old male patient who had otherwise no comorbidity. He's actually been plagued a long time with a persistent anterior fistula in ano. He was excluded to have inflammatory bowel disease, so there's no Crohn's disease found. On the MRI, we found an anterior tract which was 5.7 centimeter in length. And he had an insertion of seating to control the sepsis, and this was the status when we started with the lipoaspiration procedure and the lipofilling procedure. The picture it's rather difficult sometimes to take pictures in this position. I do have to say, I found that actually increasingly challenging. So this is the seating and the tract. We debrided the external part, trying not to remove too much tissue. We then closed the internal opening with an advanced flap, which is really not well visible, but then it's part of the problem. And then we bulked the tissue around the tract up with the injection of fat. In 3 months, we found there was complete closure with no incontinence, no recurrence, now than more than 1 year. And on MRI, there was complete resolution. We've got another patient here. It's a 55-year-old male, no other comorbidity. He had 2 years worth of fistula in ano, which was persistent. The MRI showed a horseshoe fistula here, posteriorly. He did have an advancing flap which had failed before, and he had a seton in situ for about 2 years at the time when we started to enroll him into the study. And that was in 2010. Here is a similar thing. The seton and the advancing flap and the injection. And at 3 months again, he had complete closure. He had a very minor incontinence. However, that was actually pre-existing our treatment. So he did have a bit of incontinence beforehand already. And that didn't get worse through our procedure. There was no recurrence at 2 years, and on MRI it had completely resolved. This, is Ray, is his patient, and we did some patient interviews with our first few patients. And Ray says that this procedure has given him his normal life back. There's a lot of things he couldn't do and he wouldn't do, and he wasn't really able to work, or he felt that he wasn't able to work. And after this procedure, the outlook on life has really changed him. This is Gary, our first patient, which had the most remarkable result. We haven't got any intraoperative photographs, which is unfortunate, but we've got his testimony. In 2003, he started with an anal abscess, so that was about 8 years worth. It basically got worse, and he had various attempts to fix the problem. In 2006, he ended up with a colostomy, and that changed his life entirely. He